Thank you very much. Okay, so hello everyone. Thank you very much for joining us today. This is the 19th event in the Street Drugs webinar series. So we've been going since lockdown actually, following a couple of live events. And we've covered a lot of different topics, from nitrous oxide to alcohol, stimulants, spice, drug consumption rooms. And our next event, date for your diaries, everybody, is coming up on Monday, the 5th of June. And that will be on drug trafficking and policing. And that's featuring Neil Woods and Lucy Campbell. So I'm Jo Neal from the University of Manchester, and I'm your host for today's event. Tell you what, I'm very excited about today. James Morgan and Chris Chandler from London Met Uni are partners in these events, and James is here. And Drug Science, of course, is a partner as well. We are in the process of looking for a publisher for a book based on these events. So if anyone wants to help, just let us know. As I said, we've 286 people registered. We've 100 people here, which is great. This will be recorded, so anybody you know who misses it, they'll be able to catch up. It'll be on the Drug Science website and on James Morgan's YouTube channel. When you're putting questions, please can you put them in the Q&A and not in the chat? And that enables the speakers to answer the questions for you, after they've finished speaking or whatever, and that works really well. So please put them in the Q&A and not the chat. It's easier for me to keep track of them as well. Hopefully we'll have a really lively Q&A. So today's topic is about naloxone. And I'm a pharmacologist, and it is a really interesting drug. It's a competitive mu-opioid receptor antagonist. So what this means is that it displaces the agonist, which is what is having the effect. So the agonist, which is an opioid, like heroin or fentanyl, from its site of action in the body and in the brain. So what naloxone then does is it reverses the serious effects of taking too much, or of taking any. It's going to compete for it. It's going to push it off its site of action and take its place. So basically, by doing this, it saves lives in overdose, and it acts very, very quickly because of the way it's taken. And the definition of an antagonist is it doesn't have any intrinsic activity. So it doesn't have any activity on its own. So it can't do any harm on its own. And it is an essential medicine as defined by the WHO and of course, by everybody. Okay, so I'd love to introduce you to our first speaker. I'm so pleased to have such expert speakers with us today. So Daniel Ahmed is a registered mental health nurse and an integrative psychotherapist. He is a clinical partner at Foundations and just appointed clinical director for Cranstoun. He has worked in the substance use field for over 20 years, and he is a staunch harm reductionist. So very warm welcome to Street Drugs, Danny, and thank you for being here.
Oh, thank you very much, and thanks for that introduction. So I'm going to speak to you today about, not about naloxone. I'm going to talk to you about diamorphine, so a diamorphine aperitif, if you like. And certainly, as we mentioned before we came online, it's really important that you have naloxone available if you're going to have a diamorphine aperitif. So let me share the screen and go through my slides. And hopefully you can see that. Yeah, great. Okay. So the first question really that I often get answered is why did we look at diamorphine assisted treatment in Middlesbrough, and what is the need? So anywhere in England, anybody who accesses treatment for heroin addiction and problems will be offered opiate substitute medications, and there'll be a number of people who will fail to benefit from those medicines. There will be about 5 to 10% of the treatment population that will not respond well, or as well as we would hope, to methadone, buprenorphine, Buvidal. And in those cases, we know that diamorphine or heroin can play a significant role in allowing people to stabilize their lives. And I'll talk a little bit more about some of that evidence as we progress. But back in 2017, started to explore adding diamorphine as a treatment option and intervention to the services and the service that we ran in Middlesbrough. And really, there's a perfect storm of reasons to why we looked at Middlesbrough. First of all, Middlesbrough is the most deprived local authority in England, and most of its wards, nearly half of its wards, are defined as significantly deprived. We have a significantly higher prevalence of people who use heroin and opiates, so that's higher than the rest of the North East and higher than the rest of England. So per head of population, Middlesbrough's got the highest number of people who are using heroin. And unfortunately, Middlesbrough is always there or thereabouts in terms of being at the top end of the tables you don't want to be, which includes also drug-related deaths. And we also know that we've got a particularly poorly group of individuals that we are supporting. So the average age of the patients that we're working with is about early 40s, 42, 43. But they have a staggeringly increased prevalence of chronic health conditions. So they're twice as likely to have respiratory conditions like asthma, twice as likely to have COPD, which comes with a really early onset in this group, twice as likely to have significant mental health problems. And I think, I probably haven't worked with anybody who's got significant problematic heroin use who hasn't had singular or multiple traumatic events throughout their lives, and many of those embedded in childhood. 50% more likely to have a stroke or similar events. They're twice as likely to need palliative care. This is a group of patients that are relatively young. So we're really talking about medieval levels of life expectancy in this group of people. And they are really presenting with the traumas of childhoods, but with the illnesses of old age. So Middlesbrough really was the ideal place to start to look at how could we address some of the issues by allowing access and supporting access to a potentially life-saving and stabilizing medication. Just to reiterate about the evidence, really, this is one of the most heavily researched medications that are in the substance use field. It's been used and researched internationally with multiple randomized trials, meta-analysis. The UK has undertaken its own trials known as the Riot trials nearly a decade ago, over a decade ago now. And the UK guidelines for drug misuse and dependence recognise that diamorphine has a place as a second-line intervention and is encouraged as a cost-effective, evidence-based intervention that should be available for people as they need it. Just as a flag, really, the EMCDDA Insights is freely available online and is a really good compendium of all the research and recent evidence around heroin-assisted treatment up to its point of publication. So more about the service delivery, really. We began work on this in 2017, as I mentioned, and it took us nearly 2 years to get to a point of readiness. And we went live in October 2019, and we were operating for 3 years, just over 3 years. And the model that we adopted was an integrated one. So we situated the intervention within a specialist GP practice, the foundations practice, and we only used 2 rooms, one room for the preparation of the diamorphine and one room for the administration. So it was possible to bring this intervention into relatively small physical spaces. And for us, it was key that it was integrated with the broader treatment offer, so people could access healthcare easily, and they could also access care coordination, psychosocial interventions. And we also worked with partners at the time, so the probation service would situate themselves in the service for a period of time. Mental health teams would come into the service. The ask of external partners was that we have a captive audience of people who are attending regularly, so please bring your services to them, rather than us continuing in this sort of merry-go-round of referral and DNA that a lot of external agencies were experiencing. So the patients attended the practice twice daily and self-administered diamorphine under the supervision of the clinical team. I'm going to hit a button now that should hopefully play a video. Hopefully the sound is on, but if not, there is text underneath, so you should be able to capture it anyway. Bear with. And that really explains the sort of process that we went through every single day with every patient that was involved in the program. Oh, don't want to hear that again. So yeah, I'll come on to some of the outcomes and some of the research that's been undertaken. So we were heavily researched during the program. Teesside University undertook a independent evaluation, and I'm going to talk through their findings on this slide here. But we've also had 3 or 4 other pieces of research which are in the process of being published. So we've just had recently published More Than Just Heroin, and this was a study around the staff and stakeholder experience. So what was it like to deliver this intervention within a sort of recovery orientated treatment system, and with some of the stigma that became attached to the program and the sort of media spotlight that was placed upon it. And one that has just dropped today and is being published, so they'll be both tweeted about quite a lot, I would imagine, in the next few hours. And this one is about the service user experience. So what was it like to be a participant within the program? And that's called This Is Hardcore. And I think both of those papers, you'll find some really interesting further sort of discussion points around the experiential journey that people went on during the 3-year period. And finally, sorry, there's a further piece to be published later this year, which is a health needs analysis, which really is exploring what were the significant impacts on health and in health in attitudes to health and health behavior. So the sort of highlight for that being that we saw people move from very crisis-driven access to healthcare to very proactive approach to their own health and well-being. But back to the year 1 findings. So this was a broad evaluation that just touched base around a number of areas. And And first of all, what we found is that the engagement was superb. So 97% of all the available sessions, so 2 injecting sessions a day, were attended. And we saw a reduction in the consumption of street heroin. Our primary aim was, can we break the relationship between street heroin and the participant in the program? We felt if we were able to do that, then all the other outcomes that we were hoping for, improvements in health, social well-being, so on and so forth, would fall out of that primary outcome. And what we saw is that during the random weekly tests, is that 80% of those tests were negative for street heroin. And in the time that we saw individuals occasionally use heroin, that was certainly in a less problematic manner. So it would be in response to a particular situation where perhaps they hadn't quite developed some skills to manage that, other than to return to heroin use. We also saw, it isn't documented in here, a reduction in the use of other drugs. So there was a sort of a potential risk that we would see an escalation in the use of other substances or alcohol, as people sort of jumped from using heroin, or used the sort of accusation was that because people were able to access heroin, they would simply fund an increased use of other substances. We did not see that. We saw a reduction in use of other substances people were using as well in general. We had 100% engagement with psychosocial interventions by the 10th month. So this was not a prerequisite. People did not have to engage in anything other than the provision of the medication. And but what we found is that as people stabilized, they were keen to start to explore their own well-being to different degrees. Some people engaged quite heavily with mental health teams. Others just had light touch psychosocial interventions, but everybody showed a willingness to be involved in some sort of structured psychosocial intervention. And again, a softer outcome, but probably one of the key outcomes that we didn't quite capture in the initial year, is the development of human relationships. So we really saw people grow, and people find real value in having discussions with us as a staff team about really day-to-day life issues, what people were having for tea, what was going on with somebody's football team. This became the kind of dialogue that replaced the sort of drug seeking and drug acquisition dialogue that people talked about having pre the program. We also measured individuals' self-reported physical and psychological health and well-being. We used the TOPS form, which people who are in drug treatment will be familiar with, treatment outcome profile. And we did a shortened version of the Edinburgh Wellbeing Score. We saw people's scores with the Edinburgh score increase by nearly 91%, so that people were starting to score scores that were above the average for the general population. And people reported about 100% increase and improvement in terms of their own physical well-being. I think it's 260, I can't quite see the slide here, 261% increase in terms of their psychological well-being, and I think 211% increase in terms of quality of life. So staggering changes in terms of how people valued their own well-being and perceived how it had changed during the course of the programme. The initial funding came through Police and Crime Commissioner, so there was an element of exploring the impact on crime that individuals who took place in the programme had. And we did see a reduction in criminal behaviour of about 60% with some cost savings associated to that. And we also saw a reduction in the sort of crime severity score. So if people were committing a crime, it was not at the same scale that they were doing before. And we often saw that in those cases, the crime was not necessarily related to the acquisition of drugs. It may have been for they were struggling for food, or some other issue that people had identified, other than the use of substances. And we were also surprised, but saw people quite quickly suggest that they didn't need the diamorphine in the doses that we were supplying it, and at the frequency that it was offered. So we had a number of people who moved to single doses during the first year, and a number of people who successfully finished the program within the 3-year period, moving back to either a lesser intense treatment modality, or to be completely abstinent from drugs completely. And this surprised me, that we saw such stability so quickly. I understand in some of the Swiss research that over a 6-year period, up to 50% of people can have moved on and through a diamorphine assisted treatment program. So there was often an accusation or a risk that it would bottleneck and we wouldn't be able to allow people to sort of move through a program, because we only had funding for initially 20 people, and that was reduced to 10 people. So there was a real scarcity of places for individuals. But I'm going to hit these buttons again, and hopefully you'll hear from 2 of the participants. And then Julie.
Danny, we can't hear your sound.
And that's just 2 testaments really to the many people who went through the program and reported positive change. However, I do have to sort of end on a sort of negative note in some respects. So the intervention was terminated in December 22. And I firmly believe that that's due to sort of moralistic commissioning frameworks. And I think it's important to explore that kind of context. So we were originally funded by a PCC who was really pro the program, could see the potential benefits to the local community. We had a change of PCCs whose first announcement when elected was, I am going to shut down heroin assisted treatment, which he did. He chose not to further fund the program. We were then funded briefly by Project Adder for a sort of further 12 months in 2 6-month batches, really, which meant that the recruitment was difficult because we were always worrying about being able to sustain the program. And the accusation was that it's too expensive and that it didn't reach enough people for the money that was spent on it. And I think for me, I've got to really reiterate that this is a more expensive intervention, and it works out at about £30,000 per person per year. But that has been shown to be cost effective. So because of the massive changes that we've made to the individuals who touch a program like this, we really can see again that it's cost effective. So yes, there is an increased cost, but there is a massively increased benefit to the people involved and the broader community. We sort of, in terms of the backdrop, have consistently had the PCC suggesting that he's never seen any evidence of a crime reduction, despite the research evidence that I've shown you today. So there's a blindness to the evidence. And, we're in a period of time where we have a drug strategy that talks about a need and a want to be world class, but seems to be very clearly driven ideologically, We know that this is an evidence-based world-class intervention, yet it's not available in England en masse. And that's the same for overdose prevention centres, as we've seen. So there is a really clear ideology in terms of what will be funded and whether that fits with where government wants to go. And I think Kit Mulhouse's comments kind of capture that when I look at one of the tweets that he made while he was a drugs minister, that he was keen to inoculate people who use drugs. And I think that's just a very scary position to be taking as a government, and concerns me greatly. We do have a beacon of hope, and the beacon of hope is through Cranstoun. We are successfully operating a DAT in one of our treatment areas, and we are seeing similar positive results to the services that we've seen in Middlesbrough, and that we see across the world, that people stabilise and crime reduces. So in conclusion, you'll hear that the Middlesbrough DAT failed. Do not fall for it. The treatment hasn't failed. The people who access that service have not failed. They have been failed. Commissioning has failed them, and drug users every day are being failed by not being able to access this treatment option. Thank you very much for listening, and I'll try and stop sharing my screen now.
Thank you so much. That's such an absolutely brilliant series of outcomes, isn't it? It's such a no-brainer to roll this out, everyone.
Absolutely. Yeah.
And is it different in different locations? Is there anywhere else this is happening?
So it happens all across the world. So we know that there are pockets of this intervention in various countries. There is a trial in Glasgow that's ongoing at the moment. It's delivered very differently, so it's less of an integrated program. It's got more costs associated with it, but it's another. It is the only other, barring the Cranstoun service, that we have at the moment. We're really keen as an organisation to support people nationally and internationally to take this treatment option forward. You know, we've got the skills and the expertise to do that, and we want to see it available in every town and every city in the UK.
I mean, the outcomes are extraordinary, aren't they? They're so great. Nothing else is going to do this, is it? Really?
I've not seen that level of transformation in people. It was a privilege to be around guys that I'd been trying to support with different medical interventions for the last 2 decades, and to be able to do that and see the results so quickly was just phenomenal. Phenomenal. It was a privilege to spend time with these guys and to really get to know them. That daily contact was amazing.
Yeah, absolutely wonderful. And it's so frustrating that government will not do this.
Yeah, it is for me, and I've seen nothing but hurdles when trying to implement this program, both locally and in Middlesbrough, and when we've looked at exploring it in other areas. The buy-in and the support, it's the opposite. It's hurdles and issue and problem in terms of allowing it to develop and grow. It's not there as an easily available option for people who are getting additional funding within their area. In some of the funding streams that are available, it's clearly outlined as not applicable for that funding stream. So it really does feel as though it's not an intervention that the UK wants to see, and we need to be clear that it works, and we need to fight back against that and make sure that it is available for the people who need it.
But you have the evidence of how well it works. You know, that's the most awful thing. Here's your evidence, and the success is exceptional, and that is not being accepted. Right, so I have a few questions for you. Yeah, this is a good one from Anne about the challenges that you faced. I mean, we're talking about hurdles to get it passed in the first place.
Yeah, so in terms of initially getting the program up and running, I suppose there was a sort of staged approach. The first thing was I approached the public health team locally, who were fantastic, and said, look, go away, explore it, work out, is it something that would be viable within the town, and what would it add? So I was able to go back and show them the evidence that we had. I was able to visit some services around the world and see for myself the delivery of this intervention. But we sort of had three things that we needed to understand, really. We needed to be able to do that within the legislation. That meant the acquisition of Home Office licenses for appropriate medics and for the site that we were going to use, so that we could demonstrate we could receive, distribute or manage controlled drugs and destroy them safely. So we had to understand those processes and make those applications. And even that was fraught with hurdles. So, for example, you require a consultant psychiatrist to oversee the whole program, and addictions consultant psychiatrists are a rare breed. So, and actually a lot of services that run in England certainly are not led by psychiatrists. So that was a challenge in itself. We were a primary care organisation that had good, strong medical links, but not with psychiatry. We got over those hurdles, but that's the kind of hurdle that would be in the way. The further hurdle was obviously finding the funding, and I was very lucky to have Barry Coppinger as a PCC at the time, who was absolutely determined to support this program, to look at how we could do something differently in supporting people who use heroin. The ongoing funding became the major issue, and in the end, just kept I was firefighting for small pockets of money, whilst we were celebrating the massive influx of funding into the treatment sector of the time, which again didn't fit. You know, we had I can't remember the exact amount, hundreds of millions being approved for the use of drug treatment, and yet I couldn't get £300,000 a year to continue a evidence-based program. That was the biggest long-term challenge. Yeah, and local buy-in was relatively easy. People were up for it, stakeholders were up for it. The community initially were a bit unsettled because the Daily Mail did some door knocking and sort of whipped up a bit of a storm, really. But we worked with the local community, and they could very quickly see that we weren't doing anything different. We were providing a different medicine for the same people who be coming to the same service anyway. And they started to see some of the impacts and effects that was having on the individuals of the program.
Brilliant, really. Oh yeah, I can't imagine how difficult it must have been. Yeah, really interesting question about the people who were on the program. How have you been sort of following them?
Yeah, so we still, as part of being on diamorphine assisted treatment, you are still on another OST. So they were on methadone. When we finished the program, we looked at the available treatment options that were there for them and transitioned them back to those medicines. What we've seen, sadly, is that people have sort of regressed back. So people who had found stability have lost that stability. And it's very much gone back to the sort of atypical behaviours that we saw. Some individuals were really always struggled to sort of maintain good contact with the treatment service, and were in and out of treatment or just out of treatment. That's happened again for those individuals. Some people had long histories of acquisitive crime and quite aggressive begging. Some of that behaviour has returned. Some people have lost their tenancies. People have returned to daily poly drug use. So we've seen gradually, and it's taken, it was about 3 months really before the wheels really fell off for everybody again. And that isn't, that shouldn't be a surprise. It's very, very sad to see. It's heartbreaking, but we've removed the medicine that was keeping them okay.
It's heartbreaking. It's absolutely heartbreaking. So Judith Yates is here, and she's asking about the funding, whether it should be centrally funded rather than local. Should be, I think. I don't know.
I think that makes real sense. You know, if we could have central funding, I think that was recommended by a previous Health Select Committee and previous reports. That, just as an aside, the Health Select Committee did come and visit the programme. Were blown away. They met all the participants. They will be reporting on their visit as part of the broader look into drugs and drug treatment. I think over the summer that will be released. But yes, I would agree that there needs to be a centralised pot.
Brilliant. Okay. Okay. Thank you so much, Danny. There are some more questions. You might get a chance to answer them. But I think we should probably move on now. People, you'll notice that Alex Penn, the fourth speaker, is not here. He works for Thames Valley Police and he's dealing with an emergency, so we're not sure whether he'll make it or not. He is currently preparing his frontline staff to carry naloxone, so it would be great to hear from him, but we'll just have to wait and see, just to let you know. Anyway, we've plenty to be getting on with. So I'm going to introduce our next speaker, Meg Jones. Very warm welcome, Meg. She's the Director for New Business and Services at Cranstoun, the social justice charity. Before that, she worked for 5 PCCs. For West Midlands PCC, she co-authored the 8-point plan for a new approach to drugs policy, and delivering those, was responsible for delivering against those. And one of those was leading West Midlands Police to become the first force in the UK to be trained and equipped with naloxone. So lovely to have you here, Meg.
Thank you very much. And how to follow Danny is always a tough act to follow. And the best is yet to come with Ros, I'm sure, after as well. So thank you. Thank you for inviting me. And I will try and share my screen. I am currently, quite aptly as well, in Sweden at the Law Enforcement Public Health Conference. And we have already discussed today, actually, particularly naloxone and other ways in which law enforcement can support. So let me just start my presentation. Oh, bear with me. Hold on. One sec. Right, let's try again.
It's never easy, is it? The technology.
No. Here we go. Right, can everyone see that?
Yes.
Perfect. So I just wanted to start really by setting it within a context of policing. And as you've said, Joe, I'm kind of doing this with 2 hats on, one of which is the previous hat around supporting police and crime commissioners, and particularly in partnership with Jane Bailey at Westminster Police as head of policy, supporting the drug policy recommendations. So to start with, the police in England and Wales are focused very much on Peelian principles. So policing by consent is an extremely important part of UK policing. And one of the fundamental things I always come back to around naloxone and police carriage of naloxone is about preservation of life. That's one of the most fundamental Peelian principles of the way that policing in England and Wales is set up. And also that element of the police are the public and the public are police is really important, because it comes back to trust and confidence between the police and the public. And particularly at the moment, there's a lot in the news around trust and confidence between policing and communities. And this is something that is incredibly important to keep coming back to throughout. And then within that context, we have police and crime commissioners, which exist across England and Wales. They're a relatively new and different concept for us here. And they are political. They are directly elected by the public, and they have essentially three main functions, which I've listed there. And we have seen some police and crime commissioners in particular become what we would potentially call drug policy actors. So people who have really advocated and supported a changing and different approach to drug policy. Ron Hogg, Arfin Jones, also David Jameson in the West Midlands, and as Danny said, Barry Coppinger also, who supported DAT up in Middlesbrough. So this is a really important consideration in terms of particularly setting policing priorities. PCCs have a real opportunity to narrow in and focus on priorities for their own area to support ways in which they can build also that kind of trust and confidence between policing and communities. So going a little way back to the West Midlands approach, and it was an area of work that linked in to the police and crime plan in the West Midlands, but also we had a real opportunity to narrow in and focus on particularly the drugs around heroin and crack cocaine, where the PCC in the West Midlands felt that there was a good deal of harm happening across West Midlands in terms of harm to people, i.e. drug-related deaths, which unfortunately continued to rise after this point. The cost to society, i.e. cost in terms of police force demand, but also wider cost, and crime as well, so associated crime. So it gave the PCC in the West Midlands, and therefore the force at the same time, an opportunity to look at doing things quite differently. And here I won't read out hopefully you can read the boxes, but particularly the box at the bottom, which comes directly from police officers, which went into our ambition document around Naloxone, and just really pointing out that element where it says, when those officers arrived at the scene, the man overdosing was already dead. So to them, that person was already dead. And we're not only talking about that individual, and of course, if you read on, you will see that the ambulance service turned up, used Naloxone, and actually that person came around remarkably quickly. But also the impact on those police officers as people, their mental health, the trauma of dealing with a death. These are real key considerations in terms of the importance of naloxone carriage, but also in terms of the alternatives that could be used at that scene. So it says there, despite a friend attempting CPR. So police officers will, of course, engage with that initial first aid, that CPR. But as we'll come on to as well, one of the challenges and one of the obstacles that has been around naloxone carriage has been about some opposition that has existed around officers carrying naloxone. But actually, naloxone, as probably most people who listen to this are aware, is very, very, very easy to use. And particularly for the officers who carry Nixoid, the spray option, it's even easier. That's much easier than trying to start CPR. So that was really all of the evidence that we started to pull together to inform what we wanted to do in the West Midlands, and to start by equipping and training officers with naloxone. So one of the things that I'd say is, out of the 8 recommendations that we had in the West Midlands, I naively thought this would be the easiest, and it was probably one of the hardest to get over the line. And I think timing was everything. So we started off with the Penoxad version. And just as we started to look into this, Nixoid, the spray version, became available. That really did help us get it over the line, because there were concerns from policing colleagues about needle stick injury from Penoxad as well. So the Nixoid, I would say, was a real success in being able to get that over the line, but also the comfort, I guess, and confidence of officers using that is higher. There was considerable opposition at the time, and there still is in some cases. So the Police Federation at that time was opposed to it, largely on the recommendation of it being an expansion of police officers' roles. Luckily, in the West Midlands, we had worked with a public health colleague David Neal, who at the time was doing his master's, and he actually focused on police attitudes to naloxone, which was very handy. It wasn't planned, but it all came together at the same time. And he actually did a survey of officers in the West Midlands to look at their attitudes and if they would want to carry naloxone. The first thing he found was that the knowledge of naloxone was quite low. So officers understanding what naloxone was and how it could be used, but that over 80% of officers said that they would want to carry naloxone. And actually the knowledge of naloxone and how it works and what it does has considerably increased, I think, across many police forces since. So I imagine that would go up considerably now as well. One of the other challenges was around the ambulance service and the response. So if an officer administered naloxone, would that impact on the timeliness of an ambulance coming out to that scene? So a really important aspect of this to get this over the line was to agree a memorandum of understanding with the ambulance service to ensure that call-out times were not impacted by officers carrying naloxone. And then also media and public opinion was key in terms of making sure that we were able to bring the public with us to ensure that the support of officers was there. And there are a couple of, at the time, a couple of key coverage pieces that went out across Newsnight, and then also a follow-up on regional media as well. And public opinion was broadly supportive. Because we had pitched it in a way that said, actually, police officers are supportive of this. They want to be able to help when they come across someone who is experiencing an overdose. And it was really key that we focused on the evidence around that as well. And also the examples and stories of not only police officers who had previously come to that scene, as you've just seen, but also from hearing from people who use drugs as well. And one of the other challenges was just around the training of officers and the storage of Naxolone as well. And we worked collaboratively at that time with Claire James and Craig Francis from CGL in Birmingham, who did a fantastic job on supporting the training and also storage in local services of Naxolone for police officers at the time, which was fantastic. So what are the successes of training and equipping officers with naloxone? Well, first and foremost, saving lives. So we've heard this morning at the Law Enforcement Public Health Conference from ACC, Gary Ritchie, who proudly says that Scotland now is probably the only country in the world where all police officers carry naloxone as a mandatory, as mandatory really. So that's not the case currently in England and Wales, it's still voluntary. But I do now know that over 20 police forces are now equipped with naloxone, and many others have naloxone in police custody. And you'll see there's a couple of links on the right hand side and an image as well of PC James Wild, who was also instrumental in the initial pilot in West Midlands. But a key element of this is increasing trust and confidence between the police and people who use drugs. And I've put a quote there from James at the bottom when he was interviewed on that piece, and he said, you know, why do you think officers should carry naloxone? He said, well, you know, I think that the death penalty is too harsh. And that really, you know, hit the nail on the head really with why we set out to do this in the first place. We really worked to engage with those who objected. We really worked to provide the evidence base, to provide the opinions and views from people that were already carrying it. And I don't think there's an exact number, but there have been well over 200 uses of naloxone by police officers across the UK. And I think there's well over 200 probably in Police Scotland alone, which is absolutely fantastic. So some of the learning from it, we did a West Midlands learning event very soon after the pilot, and we invited forces from across England, Wales, Scotland. And essentially, we were able to pull together a bit of a pack of risk assessment, the template MOU, et cetera, to allow police forces to be able to replicate this in their wherever they were. I think one of the things that I would say is that the continued training of officers is really, really necessary, and that needs to be embedded as business as usual in terms of learning and development. So as part of new police officers coming in, it would be fantastic to see really comprehensive harm reduction training, as well as training around naloxone, so that there is a real understanding about how the police can support and their role in harm reduction and drug policy. The evidence is really key. So we were lucky in West Midlands to have Till Shaw, who supported the evaluation, who worked in the Westminster PCC office at the time. And there was a really robust evaluation that supported it. And of course, people's stories, the police, the community, and people who use drugs to support that. So there's a couple of comments here, and you probably won't be able to read them all now. I'm not going to read them all out, but this is from people who use drugs and their perceptions of the police. So it's about building rapport, that it's much needed, that it's open-minded, that it shows a compassionate view towards people who use drugs. And it's about saving lives, logical, practical. These are all things and all the language that we should be using, and probably the same around diamorphine-assisted treatment. You know, you could probably take exactly these phrases and use it for diamorphine-assisted treatment as well. And fundamentally, I think the police and you know, seeing law enforcement is a very narrow view of the police, but actually at every point in kind of community well-being and building trust and confidence, there is an opportunity for kindness at every interaction. And I think naloxone is a really key element in just starting to break down that little bit of a barrier. And hopefully, in terms of next steps, it's not the end of it. So actually, you know, there are 20 forces now equipping officers with naloxone. Police Scotland do it as mandatory. It would be fantastic if that was consistent now across the whole of the UK, with that training embedded into business as usual and that really comprehensive training for officers. The other way that people are receiving naloxone is through police custody. So in the West Midlands, our Cranstoun Arrest Referral Service ensures that people leaving police custody get a naloxone kit and injecting equipment provision, as well as supporting with harm reduction advice. A really big one actually is around obviously the wider availability of naloxone, but even more crucially that people carry it and that they use it, because it is definitely about the confidence and to get that kit with you wherever you are. And I'll just hold mine up to show that I've got it here next to me and it's often with me all the time. And that's really important, that people feel confident enough to use it, because it is about not just policing, but expanding that access, as it says there, to probation services and to anybody and anywhere that would perhaps come across an overdose situation. And probably links back to Danny's point really as well, around this is about a compassionate approach and it's about supporting people who use drugs. And that needs to be a wider availability of heroin or diamorphine-assisted treatment, of diversion and deflection, so that people aren't criminalised through their drug possession, through custody-based support models like our Arrest Referral Service. And crucially, you know, we have seen in the UK in many places, police and PCCs really kind of pushing forward on a harm reduction agenda, because it doesn't seem to be happening in other places. And that's fantastic, but also we need to see that bit more consistently. And also it's certainly not the case in all areas. But the next step around that should be about overdose prevention centres. So this isn't one thing that we can look at in isolation. It has to be a part of a whole system approach and a whole model to support people with compassion who use drugs. I've just put on the back there as well another useful contact. So if there are people from police forces who haven't got officers equipped with naloxone, Mark Lay's details are on there. He is the National Drugs Coordinator and supports officers and forces across England and Wales with not just naloxone, but drugs policy generally. So I'll leave his details up there as well. Thank you.
Meg, that's fantastic. What a fantastic achievement You're absolutely right. It should be mandatory for all police forces. I guess all first responders carry naloxone. That's just standard. Anne is interested in supporting frontline services to carry naloxone. And I think she's interested in training resources. I was wondering about this as well for universities and I guess for the general public. We're also probably be talking about the pharmacy profession as well, because that seems like that's where you're going to get it from, or hospitals. She's particularly interested in myth busting for the professions. So I guess that's the sort of thing you do though, Meg, isn't it?
Yeah, absolutely. So and as Cranstoun, we have since trained hundreds of police officers since on training and carrying and using naloxone. And I think that bit is really important, because I think whilst we have really focused on getting naloxone out to as many people as possible, it is about the confidence of people using it and some of those myths that surround it. And actually, one of the things that we found when we did the initial pilot, when we were speaking to police officers, it was some things that came up. I'm trying to think now about that first session that we did, and just trying to understand actually how it worked, and the actual, which I'm sure actually Ros might come on to in the next session as well, but some of the science behind it, because people want to know how it works, and particularly that element of, well, if I use it and it's not an overdose situation, what's it going to do?
Yes.
So actually it is really helpful to be able to do that. And I think there are probably quite a few of us that have resources and things like that. So if there's anything that people want, then do reach out. I'm sure we can share what we've got as well.
So I'm sort of thinking about security systems for nightclubs and festivals and that sort of thing. Are those guys trained? I mean, and
Yeah,
given,
so a really good example of that actually is in Birmingham city centre. One of the main sort of nighttime economy areas is the Arcadian.
Mhm.
And all of the security staff there are trained and carry naloxone. We've had the same with security staff that visit things like car parks
Yeah.
in local areas in our Sandwell service, who have been trained and equipped with naloxone. So it literally is anyone that might come across an overdose, which is also all of us. If you walk through a city centre, it's definitely something that we should be getting out to as many frontline staff as possible, really.
No, yeah, absolutely. And I think you make a very good point about the fear for somebody who's not medically trained at all of delivering something, especially when it was an injectable. I mean, and then are you going to do some harm? So there really is a need for training to be rolled out, for everybody, and this understanding that you can't do any harm, because of its pharmacology.
Yeah, absolutely. And I think the Nixoid does help with some of those
Yeah.
challenges, as I say, that we had at the
Yeah.
start. And also I think anecdotally around friends and families of people who use drugs that feel very comfortable
Yes.
with Nixoid. It's also very easy in terms of it's very small to stick in your pocket and carry as well. So it does offer an alternative to people that are more comfortable and confident carrying that version.
So that's the spray.
That's
Amazing.
the spray.
That
Yeah.
just strikes me as so much easier.
Yeah. Well, I guess it's like when you get a cold, isn't it? And you use the exact sort of same thing.
Yes.
In that way. So people know how to use it instinctively.
And injecting somebody would be tough to do, I think, if you have no training, but of course there's training available. Yes, Danny's very, very good point about transport hubs, train stations, fast food places. Yeah, anywhere. It's a brilliant idea. And James Pierce, hello. See you on Twitter. The Loop have naloxone on site. Big shout out to Fiona Measham and the Loop. What an absolutely brilliant organisation. Now Rebecca's asking about the Northwest in Burnley. There are festivals coming up, if you know of those are the security guys trained up there?
Not sure. Don't know if anybody else does.
Don't know if anyone, yeah, so maybe somebody on this webinar knows about that. It'd be really good to know. Okay, John Finley says community first responders are not given naloxone currently. So that's something that should happen, isn't it? Oh, that's good. Everybody, all the drug services in Northern Ireland have naloxone. It's good as somebody from Belfast. That's great to hear. High drug-related deaths in Northern Ireland. Okay, so Ros, you've been doing an amazing, brilliant job of answering loads of questions. She's suggesting you speak to the local drug service provider. Actually, that's very smart. Yeah, brilliant. Brilliant. That's some great comments. Okay, thank you so much, Meg. Brilliant. Just great work. It really is fantastic. So we'll move on now to Ros, who can answer her questions live. Ros, it's lovely to have you here. Thank you so much for coming. So Ros is a pharmacist, and she is a member of Drug Sciences working groups and a committee member. So thought I'd put that in. She, of course, has been involved in delivering drug and alcohol services for a long, long time. She's now working for WDP, Westminster Drugs Project.
Yeah, imminently to be renamed, but I can't tell you that. With a new name for a couple of weeks yet.
A new name after WDP?
Instead of WDP, yeah. Rebranding is coming imminently, watch this space.
Yeah, I had no idea what WDP was, so that would be very, very helpful. So she is hugely knowledgeable, everybody, and she has oversight of pharmacy, nursing and psychological interventions for WDP. And she's also been involved in the take-home naloxone via community pharmacies, and I think this is really important because they're everywhere, but as well as other agencies across drug treatment services. So thank you very much, Ros.
Thank you, guys. That's a very kind introduction, but also how I'm mindful. I'm going to follow both Danny and Meg. I am not going to be as fancy, and I didn't have beautiful slides like those two did. In fact, I've got no slides, so that that says it all, doesn't it, really? But what I just want to reflect on, though, is that having spent some brief time with Danny up in Middlesbrough, I think I just want to support just the amazing work that you're doing up there, and also Meg, building on the work that's happening in the West Mids and the police colleagues has been amazing, and it's really, I think, set the way in which others have continued to follow. So just to acknowledge that, I think, is important. So I was going to talk, or ad lib, I think is probably a better description, about the current legislation and the challenges for those of us who are working in drug treatment services. So naloxone is a medication that's been around for quite some time now, and it's also described that it's a prescription-only medication. So that means that it cannot be supplied unless it's on a prescription via and supplied via a registered pharmacy. But with the drug-related deaths that were here in the UK, obviously continuing to escalate, even back in 2012, the ACMD, so that's the Government's Advisory Council for Misuse of Drugs, they advised that the use of naloxone should be further improved. And that's why about probably 10 years ago, I think it was back in about 2015, there was a legislative change that allowed us as drug treatment services and the community pharmacies that we subcontract to be able to provide take-home naloxone without the need for a prescription or other additional kind of legal frameworks. There are consequently products that have been licensed for take-home use. So there's actually one pre-filled injection and two intranasal products. So there was mention earlier of Naxolone, that being an intranasal, but there is another one now that Accord is marketing too. And they're fairly user-friendly for people to be able to use. But this legislative change meant that when we're issuing it as drug treatment service providers, there's no restrictions on which individuals the supply is made to, and we can give it out for free as well. Of course, though, there's no such thing as free medication, right? So as drug treatment services, we still need to be able to find the monies in order to make that supply. And furthermore, if we're doing it, if we're subcontracting community pharmacies to do it, then quite rightly, they also need to be paid for that additional work that they are doing as well. As a treatment sector, and I think it's been fairly well acknowledged, that there's been an absolute dearth of funding over the years, and that's made it all the more challenging As I think Danny spoke to earlier, very recently the sector has seen an injection of funding, but being able to ring fence it, so I think as he was talking particularly for DAD, for doing it for naloxone also isn't always possible. And just how long we're going to have this funding for, I think really remains to be seen, right? So I think being able to fund it is an ongoing challenge for us. Indeed, as we are wanting to be able to expand on our take-home naloxone, then this is going to continue to be an issue for us. And that will be even more so should we have need to give out even more to respond to, if we got an alert about a really highly potent opioid like fentanyls being out in the ether, we know we're going to give out even more kits than we're already planning in order to keep to save lives as best we can. I think one of the other really big challenges we have with getting naloxone out under the current legislation is that under the drug treatment services, as drug treatment services, we can only give supplies out to individuals. We can't give big stock supplies to other organisations, and it doesn't allow for other agencies to be able to obtain or give supplies out either. So in response to this, in a positive way, about, I want to say a year ago, probably more than that now, but relatively recently, there was a consultation launched to look to see how access to take-home naloxone supplies could be further widened, although we are still, it feels like forever now, we are still waiting for the outcome of that consultation. So I'm going to remain confidently optimistic, she says, that there will be changes to the legislation and that the provision will be widened to other organisational types as well. So as we kind of, others mentioned earlier, about thinking around police, probation, outreach, supported accommodation services, all these other really important places too. And that we can also think about how we are doing this through other healthcare settings. So there was, I think in the chat or comments about how we do this through hospitals and also through all pharmacies, so not just those that are subcontracted, without the need for a prescription or this alternative medication supply frameworks that just add to the bureaucracy really. So I just want to be clear, don't get me wrong, as Joe's introduced me as a pharmacist, I'm a pharmacist by profession, so I'm definitely all about making sure that we've got safe and appropriate use and access to medication. But I think when take-home naloxone is used in this context, I think the current legislative arrangements are really quite prohibitive. So fingers crossed, and let's see what happens. We also need to ensure that people are trained and confident, so as Meg spoke to earlier, and that we need to join up the data sets regarding supplies, so we know, get a feel for the coverage, how much we're getting, how much we're getting out, and where in the conduits we're doing to help identify where we've got that ongoing need for developments. So actually operationalizing this takes some careful thought to be able to myth bust, and some of the things that people have brought up on the chats and comments earlier. And the more we can join up these data sets, I think the better. And we're not generally very good at doing that, I think, as a sector sometimes, so there's some work to be done. I think part of the other challenge we have is that just encouraging people to accept supplies and to consequently carry them around with them actually is an ongoing challenge, and how we upskill our staff and our colleagues to be able to offer that and to be familiar with kind of good buzz phrases or ways of putting that across, especially depending on where that person is in terms of their recovery, is really key. I think the manufacturers also don't really help us out much in that the kits are actually really quite bulky. They don't fit very easily into pockets, not as well as perhaps they could do. And so there's also something about the stigma that's attached with carrying the kits, especially in the way that they're packaged, typically in quite bright colours. So really useful for trying to find and locate them in an emergency, but actually in terms of people carrying them around with them, I'm trying to it sound really difficult here. You can't have it all right, but there's something about how they could be carried perhaps a bit more discreetly so that people feel comfortable doing that. So there's a challenge for us there as well. And there's also something about a wider kind of cultural shift, I think, needed amongst the general public, and perhaps for more members of the general public, especially those who are more likely to come into contact with someone who's overdosing, actually carrying it with them too. And I think I was reflecting on this a bit. I spent some time out in Canada last year, where we know that there's a notable kind of greater issue with opioids and that the opioid epidemic out there. And actually, I was struck by how common it was to see people carrying naloxone kits, quite openly attached to their rucksacks, handbags. It wasn't an uncommon sight. And that wasn't just in places like downtown Vancouver, but in more rural or touristy areas as well. So I'm not saying that Canada's got it totally right either, and that no stigma exists out there. But I think the harm reduction approach there is really quite different to what we're currently able to do here in the UK. Anyway, back to the topic of take-home naloxone and focusing here on the UK, though. What else are we doing? Well, I think we're doing quite a lot. I'm not saying there isn't more that we could or should be doing, though. Within drug treatment services, we're ensuring to get as many community pharmacists to sign up to supply as best we can afford to do is really important. Also being mindful of the pressures that community pharmacy is experiencing. So even if we have got loads of money to be able to remunerate them, actually just them having the capacity to do that, and we know pharmacies also closing down, is also an ongoing challenge. Clearly, I am somewhat biased, but in my opinion, I think community pharmacies are really ideally placed to be able to do this work. We know that a lot of drug-related deaths occur in people who aren't known or otherwise actively engaged with our treatment services. But they may still have access to pharmacy for services like needle syringe provision, or they might be going in for their other healthcare needs. So with pharmacies sometimes being quite a hub of many communities, especially in more rural areas, this could really make a difference. I think we also need to think about how else we're reaching people, and that's where our peer-to-peer and home delivery comes in as well. So I think a lot of treatment providers increasingly are having some amazing success with really utilising the voices of people with lived experience and having kind of peer-to-peer delivery. So having peers go out and provide that take-home naloxone to be able to cascade and give that out to people, I think is really invaluable. And having that, what I describe as more of a true kind of co-production approach to how we go about it and how we really galvanise the strength of people who are either currently using or have used services. To be frank, I think they can speak with a different level of authenticity, and I think that's really essential in the work that we do. We also need to really focus more so on those really high-risk times. So looking at post-prison release, following hospital discharge, especially when the person is choosing to discharge against medical advice. And hopefully the shift in legislation will make some of this a little bit easier as well. I think we still need to do more, though, about training up of others and giving supplies to individuals and other organisations like police forces that's already been mentioned. So at that point, I'm probably best to hand back to the panel, if that's all right.
Great stuff, Rose. Rose, at the beginning, somebody asked about prescribing. This was about DAT in Plymouth. And you said you would answer the question live.
Yeah, I'm happy to respond to that, just because up until recent years, I spent over a decade living in the Southwest, so I'm aware of what was happening in that area. So I think the query was about just acknowledging there's been perhaps a perceived pressure of trying to reduce and switch everyone who was on diamorphine over to oral opioid substitute treatments. And I guess what I was reflecting on, we've got the system set up, so that Danny was talking to is different to what I describe as the old British system, which is where people are giving supplies of their injectable dimorph to take away with them and self-administer in their own setting. And when there was reference to Plymouth, to the best of my knowledge, that's what it's referring to. So I think there are quite a few reasons as to why we've seen that. Let's be frank, we know that cost is a factor. So being able to ongoing afford to be able to provide people with that medication. We also need to acknowledge the shortages we've had, and that just seems to be there's no sign of that abating. And the medication that kind of Danny's team, or when we're offering HAT in that context, is using larger multi-dose vials. Whereas if we're giving it for people to take home, it's the smaller ampules. So the shortage of that, which has been periodic, but is the ongoing supply and resilience of supply has not resolved. And to the best of my knowledge, that challenge will remain ongoing. And I think the other part about this is, which Danny kind of spoke to really, was clinicians having appropriate experience to do this. Unfortunately, it remains restricted to only doctors who can do the prescribing. And bearing in mind that increasingly services are becoming perhaps led by healthcare professionals, so particularly nurses or pharmacists, so maybe a different profession other than a doctor. We don't have enough doctors to be able to do that prescribing. We also don't have enough who are experienced in that. So actually a lot of those individuals are retiring. And we're not getting the throughput, the people coming through. And also, if we're not actively prescribing it, then they're not going to have that opportunity to gain experience. And on top of that, if the person doing that, if the doctor doing that prescribing is not a psychiatrist, then their prescribing requires supervision, and that can only be done by someone on the specialist register. And we don't have consultant psychiatrists growing on trees. So I think that all adds and compounds. So in a long-winded way, hopefully, Sean, I've sort of answered that.
That's really great, Rose. Thank you. Yeah, and having to have an addiction psychiatrist there just doesn't make sense.
Well, I think we need them.
We need more,
but we need absolutely more, and to be able to widen to others who are suitably experienced. I think is really needed. But there are no plans to change it, as I understand, anytime soon.
So, Rose, David Henstock is asking about emergency departments having programs, naloxone.
Yeah, so I think there's a bit of a, I was going to use the phrase kind of postcode lottery at the moment as to how well embedded and how much is going on here. I'm aware of some parts of the UK where emergency departments are able to, they provide it, but it's either on a prescription or through an alternative framework. I was going to say patient-specific direction, without going into too much technical jargon. There are other ways in which that can happen, but with that layer of bureaucracy, or otherwise where we've got perhaps drug treatment service staff going in and doing it as part of in-reach before the person's discharged. But of course, that's not necessarily consistent, again, in terms of resourcing and funding, or they're not working 24/7, usually, these teams. So again, thinking where people are choosing to discharge, or they come in at A&E, having the capacity and resource to be able to do that and respond promptly enough, again, is partly a resourcing issue, but hopefully the legislative change would reduce some of the bureaucracy and make that easier as well, I think. But it's just, how we galvanise, and that's why I said there's more to do there to get more people on board, I think.
So Megan and Danny, if you want to join in, answer anything, just dive in. There's some really nice comments. You were saying how bulky it is to carry and everything. And there's some really cool comments in the chat that I'll just read out. So James Pierce says a black plastic case would be very discreet, the crack pipe.
Yeah, so I've got the example. I don't know if you can see it. So this is, well, I think that's summarised it really. When I did go to Canada, this was for a holiday, but me being me, of course, I had to go and see the services, what have you. So this is actually the kit that was carried, that I observed people having just hung on the back of their so having that around. I mean, they have ampules, but it gives you a size of alternatives. I mean, this is still quite bulky, but at least you can patch it. I think if we were to compare, so that's your Chronoxad, I'm sure everyone will see this, but as a comparison, or you've got Nixoid, which is the nasal spray, of which you get 2 in your kit, and then you've got that size, or Accord are now launching their additional product. So you get 2 of those kits, and it's a bit more.
That's much better.
Well, I'm not telling you some glorified drug rep here. So everyone make their own decision and what have you. The other thing, of course, is around cost. So it's not just around what the products look like, they are to afford them. And I think the intranasal products, whichever brand you go for, does have advantages, but it is more expensive than the injectable. So yeah, we've got all that to think about as well.
Just to jump in about the pouches, the Cranstoun developed some pouches that are very similar, and that's got a lot of kit that people would maybe need in an emergency situation. So face mask, a torch if people are in dark areas. So there's lots of really useful stuff put together in one of these kits, and I suspect it's very similar to the one that Ros was showing there. And these have been really well received by people who use drugs. Who value the fact that they can clip it on somewhere and it's got everything they need in one place.
And I think the real key there as well was the co-production of that pouch with people who use drugs. So
Okay.
actually, you know, the leaflet that's within it, for example, which goes back to the point around confidence for using it. But, you know, it's like, it literally drops out, doesn't it? In terms of how you'd actually, that kind of reminder. Because it is sometimes if people have the right intentions of carrying it, but then come across it and all of a sudden it's like, oh, blimey, I've not used this before. What do I do? It's that kind of confidence at the time as well, isn't it, to support people in that situation.
And people saying how much they love the torches. That seems very smart.
Yeah. Well, it is often, I don't know if Danny and Ros, you agree, but when you watch these videos sometimes on training of how to issue naloxone, it's in a kind of white background, sterile environment, you know, and that's just not where you come across an overdose, is it? So, you know, you need to be as equipped as possible, really.
So Josephine's talking about A&E, and she says they can dispense, but it needs to be prescribed.
Exactly. And so hopefully this shift, fingers crossed, legislation shift will widen that and make that easier so they could give it out. I'm not saying without any record, we still need to capture, as I said, the data side, but far easier than trying to find your junior doc or whoever to write that script. That I'm hoping that if there is a legislative change that may improve, hopefully.
So Judith is in Birmingham, of course, and she has seen deaths over the last 5 years with tramadol and oxycodone. She says, do you think all GPs should be prescribing nasal naloxone to all of their patients who are given opioid painkillers outside end of life? Actually, that's interesting.
I have a strong view that yes, only because I'm doing a fair amount of research and particularly with a focus around over-the-counter and prescription medication misuse. And I have a personal view that we are not paying enough attention to this space. So again, thinking about, should it be prescribed? So thinking around the added cost that prescriptions add and all the rest of it. So thinking, you know, so looking at alternative frameworks or ways around doing that, I think is important. But I would really welcome looking at how we may be able to create greater awareness amongst doctors, pharmacists, nurses, so prescribers, but also the people supplying it, i.e. pharmacy teams as well. I think would be really important, and there's more development to be done, I think.
Well, so I wonder, is it on the curriculum for trainee doctors, pharmacists?
As far as I'm aware, the curriculum doesn't cover that minutiae detail. You might have something broader around drug use, but it's very, very variable as to what is covered. And I think that speaks to some of the work we're doing within drug science and the educational side to see what we can do to hopefully embed and create resources and raise awareness. So no, I think is the short.
I think that's right. I don't think
not enough, I think, yeah.
And you know, all pharmacists could easily have a training in the uni. You know,
but it is one minutiae amongst everything else they've got to cover. And of course, as of 2 years' time, they'll be graduating as prescribers, so it's even more to fit into an already very busy MPharm degree. Where I teach or have input into university courses, it definitely gets covered.
Of course
there are others obviously doing the same, but there's not many of us specialists involved in undergrad teaching, so we need to infiltrate and get it out there. But it's
and cannabis, medical psychedelics. That's a lot.
We'll put it on the list, Joe, for the education.
It is quite a big list, Ross, isn't it?
It is.
So Daryl Boland has a lot of information about Manchester, Beat Herder. Right, and I it's too much for me to read out. I suggest that people cut and paste that, because that looks brilliant information for anybody who's up in that neck of the woods, talking about John Cahill. I can't really read. Sorry, Daryl, I can't read fast enough. But it's in the chat, and I think, you know, if you're up that neck, I would cut and paste that or copy it.
I just want to capture, I've just seen a question from Diana around prescription opioids with naloxone inbuilt. So they do exist and we do use them. But of course, the those are for oral products, and the naloxone only becomes activated if it's then diverted via either injection or snorting them. So it's more of a diversionary kind of formulations rather than what would stop an overdose, if that makes sense.
I think the formulation's very tricky there. I was talking to a
It's
friend
also
of mine.
expensive. So again, so it's something we look at if we're concerned around that kind of diversion risk, but it would stop an overdose per se.
Yes, yeah. Okay, Nigel is collecting data on near misses and naloxone used in his area. That's interesting. He says they don't do it, but they're very good at recording drug-related deaths. So that actually, Nigel, that sounds like a very important thing to be doing, to be collecting that data.
I think just jumping in on that point, there's pockets of work that are going on, but we're not quite there in terms of having all stakeholders fully involved. So, for example, we've been doing work in terms of trying to target people who've had near fatal overdoses. So identifying people who've had a near miss and being able to offer intensive intervention to avoid it becoming a fatal overdose. But a big missing gap is the sharing of information. So that might be that an overdose may be reported to an ambulance, somebody decides not to go any further than ambulance care, they aren't given a naloxone kit, and then they subsequently either overdose, or the drug treatment service is not aware that that event has happened if they're open to them. So we really want to encourage that information being shared. Similarly, if people go into hospital, so some services do get access to some of that information and other services don't. But again, we're missing a bit of an opportunity because people, there's strong evidence that if you are starting to have near fatal overdoses, then there is a higher risk of a fatal overdose. So we need to be intervening at those points rather than, as Nigel points out, recording the tragic circumstances of somebody's death.
No, absolutely. Yeah, that's a really good point. So there has to be some mechanism for recording all that and getting that information.
We definitely need to do more around improving our data sets across the country and joining up between providers, to get that more robustly done, especially if there is hopeful scope to broaden that provision. Even more important, I think that we get that sorted. I've just seen a comment as well from Judith just about, have we mentioned the excellent peer groups? Hopefully, I think I did, but I guess I just want to use that opportunity to re-emphasize the amazing work, the peer-to-peer work that's happening. And I'm aware that I'm joining today with my technical WDP kind of badge on, but I'm, as far as I'm aware, I think virtually all our services are doing it, and other providers the same. I think we just need to embed it more and keep developing it. But yeah, to have those our peer mentors, or whichever equivalent titles you want to use in different organizations, is really, really, really important. And yeah, just to highlight the crucial role they play is really key.
Let's see, and Garad has put a comment about what happens in Swansea. They're currently linked closely with the A&E departments. These Midlands coming in. There's loads of really good stuff in the chat here, everybody. Right, so if there's a non-fatal overdose in Swansea, they will offer an intervention after discharge within 48 hours.
Brilliant.
For over 18s, 24 for under 18s. Brilliant. And that's had a massive impact on individuals accessing service.
And so I guess it's about, so how do we embed that sort of practice and resource it consistently across the UK, right?
Yeah.
That's the
Absolutely.
challenge.
Yeah, and Emma's talking about what happens in East Midlands, the referral pathway. Great, okay, we could go on all day and all night probably. So I am going to close this, I think, now, folks. Loads of comments in the questions chat. Thank you so much, everybody. Thank you for coming, being such a brilliant audience, actually, really. People have got lots of expertise, and this has been just brilliant information sharing. But a massive thank you to our speakers. Roz, Megan, and Danny. Just, I've learned so much. It's such brilliant work you're doing. Absolutely lovely. Fantastic. So, yeah, thank you very much indeed. And this, folks, this is recorded. It will be on the Drug Science website, and it will be on James Morgan's YouTube channel. So all your colleagues, your friends, everybody who wants to know more about this will be able to get access to it. Brilliant. Oh yes, and thank you very much, Mags. Our next event is on the 5th of June. It's on policing and drug trafficking, and Neil Woods will be here, and Lucy Campbell, who's up in Edinburgh. Brilliant. So yeah, thank you very much, and have a great weekend, everybody. I hope it stops raining up in Middlesbrough, Danny.
Fingers crossed.
Fingers crossed in time for the weekend. Okay, thank you very much.